Good afternoon, everyone. Very happy New Year to you, first of all. From the Department of Cardiology, we are going to present this combined round, and we are taking the topic of trauma. And the trauma is a topic which is unusual for cardiac cases, cardiac patients, but it's extremely important one, both because of its rarity and also because of the variety in which it can present. So we'll presenting two cases of trauma, and Dr. Praveen, our senior resident, and others will be presenting this case, and after that, Dr. Saurabh Gupta will be discussing it.
Good afternoon, everyone. Welcome to the CCR for today. So I will be presenting both the unusual cases, which is the interesting cases which came to us, and both of them had a blood and cardiac injury. So if you see our first case, the patient was a 9-year-old female child who is a resident of Uttar Pradesh. She came to us with the complaints of dyspnea and excision, which was a functional class 2 for the past 4 months at the time of presentation. So if you see the timeline, at the time of presentation, the prime complaint was the dyspnea and excision, and along with that, the patient has a decreased urine output, which was there for 2 days. But on elaborating the history, there was no other significant history we could get. There was no history of palpitation, chest pain, syncope, abdominal pain, or any other swelling of legs. No history of cough, hemoptysis, weight loss, or contact with tuberculosis. At the time of examination, the patient was found to have a tachycardia of around 108 per minute heart rate, and a tachypnea, which was around 35 per minute. Elevated JVP was there, and there was a distended neck veins. And there was cardiomegaly, and on auscultation, the patient was having a muffled heart sounds, but there was no murmur. And other system examination, except for the hepatomegaly, other system examination was normal. And the liver was around 3 centimeters below the right costal margin. So for this, the patient was presenting shown in the outside hospital, where an X-ray and echo was done, and that the patient was found to have a cardiomegaly in X-ray, and in echo there was a large collection which was present anterior to the right ventricle. And further probing the history, we got a very significant history. The history of blunt chest trauma, which happened almost around 1.5 years back from the time of presentation. So the history of trauma happened while she was riding motorcycle with the parent when she fell down and sustained injury. At the time, they showed it in the local hospital, but chest X-ray and NCT was done, which was said to be normal at the time. And the patient didn't have any other complaints, and except for this dyspnea in the last 4 months. So at the time of examination, this is the X-ray we had. We can see the cardiomegaly. This is a very huge cardiomegaly, almost occupying the whole thorax. So if you calculate the CT ratio on this one, it was coming out around 85%, and there was also a pulmonary oligemia that was present. So this was the ECG of the patient. The heart rate was nearly around 100 to 110 per minute in this ECG, and there was a patient was also found to have a right atrial enlargement shown by this P wave, which was the amplitude of around 3 mm. And other than that, the patient has a low voltage complexes. In this one, the chest leads which was showing less than 10 mm. which are suggestive of low voltage complex. And also the patient has a right axis deviation. So this is the echocardiography of the patient. Left side is the normal subcostal view of the patient, which is showing the right atrium, RA, right ventricle RV, LA and LV, left atrium and left ventricle. And this is our patient's echocardiography. If you can see, we cannot delineate the chambers at all. Almost all the chambers were collapsed.
So let me do normal echo for comparison.
Yes. So if you see this, we can almost all the chambers were collapsed, and there was a large collection. And if you see the small gap in between between the arrows, there was a communication between the right atrium and this collection, and this is the whole collection that was present anterior to the RV. So we did a color flow Doppler. So here we can see at the same area where there was a gap, there was a rent. We can see the blood flow going in and out of the communication between the collection and the right atrium. So since it was an unusual case and unusual presentation, we wanted to confirm whether the print was definitely there or not. So we want to be very sure about that. So we did a saline contrast echocardiography where we mixed a saline with a small amount of air. So microbubbles are formed and we inject into the venous system. So this is after the injection, we can see clearly that usually that has to come from the RA to RV. But here we can see once the microbubbles enter the RA, it goes directly into the connection which is present anterior. So the primary diagnosis was made, which was the right atrial pseudoaneurysm. Since the patient had a history of trauma also, right atrial pseudoaneurysm was the diagnosis made. But the close differential diagnosis would be the localized pericardial effusion anterior to the right atrium and ventricle, but it is very unlikely since we have demonstrated the rent that was present through the saline contrast echocardiography and also through the current. So since this patient had a very large collection, we want to delineate the area and the extent of the aneurysm itself. So we did a CT scan. So this was also similar to the one we were found in the echocardiography. We can see the two rents that was present between the right atrium and the collection that was present anteriorly. And on measurement, the collection was amounting to a huge 12 centimeter cross 15 centimeter collection was there. And it was close to the anterior chest wall, which was impact during the surgery because after opening the sternum, the collection will be the one directly below the sternum. So we went ahead with the surgery. So if we see the intraoperative findings, this was a reflected pericardium. Once we opened the pericardium, there was a huge pseudoaneurysm that is seen here. So this is a huge pseudoaneurysm that is seen here. On opening the pseudoaneurysm, there was a blood collection that was seen inside. So we evacuated the blood from the CT side, and after that we can see the communication that was present between the right atrium and the sac, and we can see the pectinate muscles also. Then once we evacuated this, we closed the sac. So this is the post-operative course. It was very unusual. The patient was extubated within the 48 hours, and this was the X-ray compared to the previous X-ray. The cardiomegaly has significantly come down, and this is the echocardiography after that. Here we can see the chambers clearly, which was not present in the initial echo, and there was a small collection still there, but the patient was okay. So with the follow-up, patient discharged the patient. So follow-up was done at 6 months. The patient improved significantly. The NIHO functional class 1. The patient, there was no tachycardia, no JVP. The patient was absolutely normal. So this is the echocardiography which was done 2 days prior. We can see the collection which was present here. So almost gone. But in other views, we were able to see the small collection. But at the same view, we couldn't see the collection here. And the function, everything was fine. And this is the X-ray 2 days prior. Even the post-operative, from the post-operative period, the cardiomegaly has significantly come down to almost a nearly normal state. So if you see the blunt cardiac injury, the injury to the cardiac chambers occurs in nearly 0.2 to 0.3% of the cases. And most common chamber involved is the right atrium, which is present in nearly almost 40%. Not only the pseudoaneurysm, other thing which can happen are the contusion, valvular damage, dissection, even arrhythmias. And this patient does not necessarily need to have a presentation immediately. They may also have a late presentation like similar to our case, who presented nearly almost 1.5 years. So coming to pseudoaneurysm of heart, it is nothing but the content rupture of the blood vessel or the myocardial valve. So if this is the left side picture, we can see the first picture is the true aneurysm where almost there is a bulging of the whole ventricular wall itself. And below that there is a pseudoaneurysm where the blood is contained in the pericardium, and there is a blood flow to and fro from the wall also. So these are some of the locations where and what are the common predisposing conditions in the table. For our case, the atria, the most common will be the trauma and followed by some ablation procedures. But if you see right atrial pseudoaneurysm per se after blunt cardiac injury is still rare only, even though our right atrium is the most common chamber involved. So as we said before, it is the most commonly caused by the trauma itself, and other causes includes cardiac catheterization and malignancy, and sometimes it can even idiopathic cases has been documented in literature. So in some on literature review where there was isolated right atrial rupture from the blunt cardiac trauma, we can see the site of RA rupture. Most of them had a right appendage rupture, and free wall rupture was present in nearly 15% of the cases. And in this presentation, most of the patients came with the hypotension, and there was a mortality of around 11% in this patient. Our patient was very lucky since the patient presented very late with the lesser symptoms compared to. And if you see the mechanism of injury, why this rupture happens, two things happen there. One is the rapid deceleration, which causes the change in the velocity, causing the shear forces to act upon. And another one is the direct impact, which causes the increase in the pressure inside the chamber, which is containing the blood, causing the hydraulic effect. Both will cause the RA rupture. Since this right atrial pressures are very lower, the accumulation will be very slow. So the patient will be most of them will be maybe presenting later in the time period. And the management, if you see, it will be the surgical repair only. So coming to the second case, this was a one spectrum where the patient was presenting to us like this, and another case who sustained the cardiac injury, I will be presenting the another case. So our second case, he was a 8-year-old boy who was a resident of Delhi itself. He had a history of blunt injury to the chest. So if you see the injury that happened compared to the prior one, here while staying at the home, there was a gas stove explosion. The patient tried to run away from the explosion, time in which he hit against the door, edge of the door. So it was more or like a deceleration injury, and the history of blunt trauma to the chest was there at the time. So initially he was okay. There was no complaints. Nothing was there. Post after 10 days, the mother noticed there was an increased neck pulsation which was seen there. Otherwise, on probing the history, there was no history of palpitations, no chest pain. There was no history of syncope, no other complaints, no decrease, nothing. No history of other injuries were there, and no other contributory past history was also there. But otherwise, the patient was almost asymptomatic, except for this noticed neck pulsations. For this, the patient was shown in the outside hospital. There, they found the patient to have a tachycardia. So they gave adenosine which was not reverted, and so they started the patient on amiodarone. And even on amiodarone, the patient was found to have an ongoing tachycardia. Still, the tachycardia was persisting for 2 days. So the patient was further referred to our hospital. So at the time of examination, the patient was awake and alive. If you see the tachycardia, the patient was there for almost 2 days, 240 rate. The tachycardia was ongoing, and the pulse was regular, and prominent carotid pulsations were seen. Otherwise, the patient was hemodynamically stable, blood pressure was normal, and respiratory rate, everything was normal. On physical examination, the patient was found to have some healed aberrations that was present over the chest. On auscultation, there was no appreciable murmur. And respiratory system examination, the bilateral air entry were present, but in right side infraaxillary region, there was a decrease in the air entry, and there was a dullness also. Otherwise, periodontal examination, everything was fine, and CNS was unremarkable. So this is the ECG at the time of presentation. If you see, there was the tachycardia, which was around 240 per minute, and this was a broad complex tachycardia. The QRS was around 120 to 140 milliseconds. So it was a broad complex tachycardia, and there was a left bundle branch type pattern was also there, and the axis was in the inferior axis. It was coming from above. So this was a monomorphic ventricular tachycardia. There was no other different complex was there, and inferior axis was there. So the origin lies likely from the right ventricular outflow tract. So this is the X-ray that was done. Here we can see corroborating with our clinical findings. There was a right side pleural effusion also, and on ultrasound chest there was 3.5 centimeter pleural effusion, and there was a mild ascites also in abdomen. So in initial investigations, CBC, platelets, everything were fine. KMT was normal, but TROP-T was elevated. TROP-T was elevated, which was suggestive of some myocardial injury that has happened during the trauma. And CKMB was borderline elevated, but although it was not significant. Echocardiography, everything was normal. Structure, normal relations, normal function, no septal defects, nothing was there. Severe LV dysfunction was there. Ejection fraction was around nearly 30%, but this was most probably due to the tachycardia itself, because at the 240-250 range, we won't be able to see the ejection fraction correctly. So since the patient, even on high dose amiodarone, the patient was having an ongoing tachycardia, we decided to do the DC cardioversion for the patient. So we gave the DC cardioversion at around 0.5 joules per kg dose. So once we gave the DC cardioversion, the patient reverted back to the normal sinus rhythm, which the ECG I will be showing. This is the ECG which was immediately after the DC cardioversion. So we can see the rate has become normalized at around 80 per minute. The normal sinus rhythm has been restored, where the P wave is followed by the QRS complexes. And in addition to that, we found an RBBB pattern also. This in further signifies that there was some significant injury that has happened to the right ventricle or right ventricular outflow tract region. So the patient after conversion has a prolonged QTC, which was nearly around 460 milliseconds, and this prolonged QTC, otherwise the patient was having a normal electrolytes, magnesium, potassium, and calcium, everything was normal. This was most likely due to the amiodarone itself, because the patient was receiving the amiodarone for almost 2-3 days and high dose amiodarone. So further, the patient was started on the beta blockers, and amiodarone was orally started after 2 days, and after that the QTC was normalized also. This is the chest repeat chest X-ray which was done post cardioversion after 3-4 days. We can see there was a resolution of the right pleural effusion which was found earlier, and also the echocardiography has showed the improvement in ejection fraction, where from 30% the ejection fraction improved to nearly 60%. Since the patient has a history of trauma, elevated biomarkers, and ventricular tachycardia, cardiac MRI was done to delineate to see whether there is any other aneurysm formation in the right ventricular or RVOT region, or any other significant abnormality that could be found. So my colleague Dr. Alameli will be showing you the cardiac MRI images. So Dr. Alameli, please.
So the first two are the short axis gadolinium enhanced images, and the third one is the T1 mapping. So in the first two images, we can see the whitings are the LV enhancement. So here we can see there is the RVOT is being dilated, and there is LV enhancement in the anterior free wall of the RVOT, and also in the RV side of the interventricular septum. And this is the next section where similar LV enhancement seen in the free wall of the RVOT, as well as in the RV side of the interventricular septum. So this LG sequence suggests that it is a dense scar.
So MRI was show of a scar in the RVOT, and the scar was present in anterior to the RVOT region, and also there was in the RV side of the interventricular septum it was there. So which was suggesting of fibrotic changes which has already happened. This MRI was done nearly 21 days, almost like 3 weeks after the trauma itself. So final diagnosis with the history of a blunt trauma to the chest and ventricular tachycardia from the RVOT region, and the MRI showing a RVOT scar. The final diagnosis was made, which was the blunt in cardiac injury, which resulted in the myocardial scar, which led to the arrhythmia itself. The patient was discharged on amiodarone and beta blockers at that time, and during the stay, there was no further episodes in the ward. In follow-up in 6 months, this follow-up was done telephonically 2 days prior, and according to them, the patient was fine. There was no increase in neck pulsation was noticed. Nothing was there. The patient was fine. The patient was on amiodarone and beta blockers. The plan is to stop the amiodarone. Then, if the further episode happens, then the plan is to do the electrophysiology study with consideration for the RFA ablation. And if RFA ablation is not possible, then the recurrence, the patient may need an ICD, implantable cardioverter defibrillator. So if you see the one spectrum where we saw there was the aneurysm formation, here we had a blunt cardiac injury with the arrhythmias. So most common arrhythmias if you see in the literature or wherever you see post blunt blunt trauma, the sinus tachycardia is the most common presentation, as we all know. Followed by that, it is atrial fibrillation, and the patient may also have an atrial and ventricular ectopics, and sometimes the patient may have ventricular tachycardia, even ventricular fibrillation, which is usually rare. So if we see the arrhythmias and blunt cardiac injury, according to the timing of presentation, we can see two type of presentations. One is immediately following the injury, famously known as the commotio cordis. So due to the mechanical stimulation of the heart by the non-penetrating impact to the myocardium, there is a ventricular fibrillation, and the patient most of them will succumb to the ventricular fibrillation and die on the field. Which is most commonly seen in areas where there was a high intensity sports area. And later after injury, as late as 20 years after the injury also, there have been cases documented. This is primarily due to the myocardial contusion that happens, or ventricular aneurysm that develops, or the fibrosis formation. Most of these patients have a ventricular tachycardia as a presentation. And reviewing literature, as I said before, sinus tachycardia is most common arrhythmia that is present post-trauma. Atrial fibrillation can be present in 1 to 6% of the cases, and ventricular arrhythmia is rare. So management of this chronic ventricular arrhythmia post cardiac injury is very less known, because if you see the literature review, this is not commonly documented. And I was able to found one case series where nearly 7 patients they published. Out of this small case series where all the patients had a VT, the patient was started on amiodarone and everything. Out of this, 6 out of 7 patients had a recurrence of VT. So in this, 5 patients underwent ablation procedure, and 1 patient they were not able to do the ablation, and the patient underwent the ICD implantation. So VT in this case is usually monomorphic with the LDB morphology that similar to our case, since RV, right ventricle, being the anterior structure to get injured because it is directly below the sternum, so it is the most common area where it get injured. And the blunt cardiac injury is usually difficult to diagnose because it does not correlate with anything. It has a very poor correlation with the cardiac enzymes or echocardiography. But ECG in major studies that was published in literature review or the retrospective reviews, they found the sensitivity and specificity of the ECG to be around 96% and 47%. And especially in some studies, they have shown that if you combine the ECG along with the normal troponin levels, if the ECG is normal troponin level is normal, we can rule out a significant cardiac injury with high confidence. So based on this, the Eastern Association of Surgery of Trauma has recommended once the patient comes with the blunt chest injury, the initial admission ECG has to be done obtained in all the cases. So if the patient does not have any ECG changes, the patient can be discharged. But if the patient is found to have some ECG changes, then the patient should be at least observed for 24 to 48 hours. And these patients may further need a troponin level evaluation or echocardiography itself. So conclusion, the blunt cardiac injury, although rare, should not be omitted, and it can result in mechanical injuries which range from a simple myocardial contusion which may be asymptomatic or to the major myocardial rupture and death. There are other manifestations also. We have described pseudoaneurysm or arrhythmias here, and there are other injuries to the heart, including the valvular structures also. They may remain asymptomatic initially, but they have present later with the unusual presentation. So we should have a high index of suspicion, and the history should be thoroughly thought so that we can make a diagnosis. And blunt chest trauma, cardiac evolution should not be omitted. Whoever have a blunt chest trauma, the ECG at least has to be done and has to be included as a part of the evolution itself. Thank you.
So these two were very unusual cases. Usually when we think of trauma, we think of polytrauma, accident related, and what we are used to see in cardiology is pericardial effusion secondary to adjacent structures being injured. And as has been highlighted, these trauma injuries which are blunt chest, we know that if somebody falls on the head, then CT becomes part of the protocol. But same is not true for cardiac evaluation. I think the message we should get from these cases is that if anybody is giving a history of blunt chest trauma, which can be as innocuous as hit on the door, at least ECG is warranted. Even then, we may miss some of the cases, but they'll be picking up some of the cases which are, arrhythmic like this. Unfortunately, our patient did not have a recurrence of VT, but we need to be watchful since the literature, whatever little is available, is suggesting that there can be recurrence. So we'll be watchful looking at that patient, and we have the follow-up till 2 days back, but we'll follow them up and update accordingly. If there are any questions, we So pseudoaneurysm is repaired. There is no structural abnormality which is remaining. So I don't think there is any more medication which is required. No, that was, we know the reason for pseudoaneurysm there. The sac has been removed and it has been surgically repaired. So I don't think so.
The pseudoaneurysm sac has been completely removed. So there is no, technically, there is, except the suture line, there is no scar.
So Dr. Pradeep has operated on the case, and I think when the patient initially came, we thought that it is something acute that has happened, because at that time we didn't get the history. But on probing again and again, because we are not secure on the diagnosis, we realized that the trauma has happened and possibly that is the cause. There are only few reports which are published in the literature. we'll be definitely pushing them into the publication also, because these are, if they are known, we can make the diagnosis faster.
In this case, the main peculiarity is the enormous latent period. Nowhere in the literature such a long period is. That makes it quite unique. In fact, we had a bit of a diagnostic dilemma whether to operate on emergency or to be.
So initially, like within few hours, we wanted them to operate, but then we realized that no, it's okay. So we waited, evaluated, and then only did. So that's what Pradeep is telling.
Which one is ECG and troponin? Which one will be more useful?
Sir, troponin may not be available at all the places. ECG is widely available, so I would say that ECG should be part of the evaluation. If trop is available, that gives us direct evidence about the cardiac injury, because troponin is elevated in myocardial injury, whether it is ischemic, traumatic, or any otherwise. So sensitivity wise, maybe troponin should be part of it, but logistics would make ECG as the first investigation.
So did you do the biopsy of the tsunami?
Yes, the biopsy came as on the wall. The sac wall came as fibrotic. The only fibroblast was seen. No, except with some adjacent RA tissue, which has been, they showed like some RA tissue. But majority of the tissue was like showing only fibrotic.
Color it was appearing as if there was an injury, there was a clot formation which was contained by the cadum. The center of the clot has dissolved and the fibrous system.
In fact, the wall was
Basically, whether to call it a pseudoaneurysm, because pseudoaneurysm, except the epithelial, it has to have the outer wall, this thing. But from the look, it was appearing.
So we had a long discussion even with the pathology team, sir. And on imaging everywhere, we felt that the blood is swirling within the cavity. Even when it was opened, we could see that there was a lot of blood. So pseudoaneurysm also, sir, maybe it was a long duration in which it got stressed out and became fibrotic. Initially, it must have been RA walls. That part we cannot say because it's 1.5 years back. Over that period, some changes would have happened, sir. But we didn't have any other alternative way to explain it. So we labeled it as RA pseudoaneurysm.
Like, what was the chest wall shape? Child?
Sir, cardiomyopathy, like
What the chest wall?
because
In, they have narrow space between the vertebra and these things. So slightest injury during exhalation. Because in exhalation, the pocket handle, the sternum goes up and away. So there is a space. But suppose there is congenital chest wall is deeper.
No.
Chest wall is deeper.
This patient did not have. This patient had no normal, sir. There was no excavatum or carinatum deformity, sir. It was fine. It was normal. It was normal.
Question about
Sir.
the second case.
Sir.
It seems like a very short period for fibrosis to have developed to the extent that showed up on the scan.
Yes, sir.
Any comments about that?
Yes, sir. So again, that thing kind of bothered us also, that why it has happened. So the scan was 3 weeks after the trauma, sir. So we kind of took clues from what happens in acute myocarditis. Sometimes in 3 to 4 weeks time, we do see some lesions. It was more than what we usually see. So that was point of contention when we were discussing. But since it was matching with our ECG, arrhythmia, axis, localization, everything, we thought that it has to be the same. Plus, it is the lesion is on the anterior wall and opposite septal wall. So possibly there was an impact like this. It was not a circumferential lesion to think of any other possibility. And that's how we thought that it has to be trauma related.
Then possibly the myocardial scarring happens very quickly. We know from myocardial infarction that such a G is found even after 24 hours. Okay. Such a G is found in memory. So myocardial somehow the myocardial necrosis happens and possibly that is referred to as fibrosis.
By definition, you are correct. Pathologically, only after 6 weeks you will get the evidence of scanning. Otherwise, acute goes up to past week, 6 days, then 6 days to 30 this thing, and then after 6 weeks you get proper scanning of that.
What was the mechanism of this arrhythmia?
Sir, as we showed in the MRI, there was a lesion in the myocardium in the RVOT regions, right ventricular outflow tract. So sometimes when there is a scar, no, sir. It's the right ventricular outflow tract has a lesion which acts like a trigger, and the beat starts from there instead of the normal sinus followed by AV node. So that beat takes over the normal rhythm, and it is a ventricular origin of the beat. So there is a ventricular tachycardia of right ventricular outflow tract. That was the.
This is something which MI also tells patients, like there is some spinal infarction, there is inhomogeneity of electrical activity. Patients are same thing, like he started want to produce healthy.
So thank you everyone, and we thank the CTVS team to support us in this. Thank you.